Hi everybody, Jennifer Blevin-Smith with Integral Clinic Solutions, and you're watching my YouTube channel, Navigating the Business of Medicine. Today is the second video of my series for Revenue Cycle Management, or RCM. The first video, if you haven't seen it, check that out. It goes to the points of where the revenue cycle actually starts in a practice. And now today we're going to pick up from there, and we're going to talk about when patients actually go back to see the providers and care plans are established. So a patient has seen a provider for whatever issues or challenges that they're facing health-wise, and the provider puts together a care plan, differential diagnosis, things that they want to do to eliminate some of these possibilities, and things that the patient is going to need to make sure that they can figure out what's going on or to keep them healthy. So that means there could be labs done, imaging done, referrals given, etc. Prescriptions prescribed. I mean, all of this stuff is what happens in your mid-office, right? So you have either medical assistants or nurses or both that take part in this with the providers. So if you have any kind of staff that's going to be drawing blood, administering tests, etc., chances are, I'm guessing, you're probably going to be having them responsible of making sure that that type of services that you need to bill for are going to be added into that chart note. Now, of course, I realize that not all of this can be billed out by you, because if you're giving orders to go have imaging done at another facility, you don't bill that out. If you're only drawing the blood, but you're not processing the blood test and it goes to an external lab, of course, you're not going to be billing for the processing of the labs. But for any point of care testing that you do in-house, any kind of injections, therapeutic medications, etc., you do bill out. This also includes any DME that you're issuing to patients. Anything that you actually do yourself needs to be captured in that progress note. And when I say captured in the progress note, part of the revenue cycle is not only the coding, the CPT codes to capture those services, and the associated diagnosis codes for each of those CPT codes for the services, but also supporting your decision and why you ordered everything in your progress notes. So providers have to be sure that they are documenting thoroughly every reason medically necessary detail in their progress notes for their patients and why they're doing what they're doing. Now, this is where a lot of providers, because administrative burden has become so cumbersome with a lot of practices, a lot of specialties, and just in healthcare in general, this is one area where providers try to skimp, or they try to cut corners. And I don't encourage that, because insurance companies are getting more and more needy, if you will, and they're requiring documentation to support the medical necessity of ordering certain things. As of a month ago, I think it was, Cigna released a notification that anytime a modifier 25 is used on a claim and billing a separate procedure, you have to send chart notes with it to support why you're billing everything at once. And I think this is just kind of the tip of the iceberg that we're kind of trending towards with insurances. And so making sure that you are supporting every decision that you're making and things that you're ordering is super important. Also, there would be no question about fraudulent billing if they looked at chart notes. Hopefully, it would lessen your liability or likelihood of having any takebacks, and it's just good practice. So making sure that you're capturing all of that data accurately in the progress note, and why you're making that decision, and why you feel it's medically necessary, and what it's going to tell you or help you rule out. And then going back to those CPT codes for those services. So, the doctor or the provider might bill for the E&M level code and something else, but are you going to be asking your staff in the back office to make sure when they have a venipuncture, when they've ran a strep test, a urine pregnancy test, a UA dip? Is that going to be the responsibility of your back office staff when they actually administer those medications or run that test to be recording it in the progress note? Or are you going to expect your providers to make sure it's captured? That's something you need to figure out internally, but it's important because so many people lose revenue on something so simple. Another thing is making sure that you're adding the correct amount of units to be billed for these CPT codes. And that goes to your biller and coder. You should have somebody who will be checking that. But before it gets to a biller and coder, it needs to be finished in the progress note. So whose responsibility is it? Have you set those expectations? Once the progress note is completed and it's signed off by the provider, then that's when it should go to the coder/biller. And this is where the coder/biller needs to be looking at these progress notes, looking at the codes that were entered and making sure that nothing was missed. I can't tell you how many times somebody only billed out for one rapid flu test when you can bill twice for an A and a B ran at the same time. Or they're missing amount of units for a J code, a medication that was administered. And so hopefully you have a well-educated coder biller that can look back at this and make sure that they're capturing everything that can be billed out. Your coder should also be making sure that you're not overbilling for anything and you're not underbilling for anything, because you can get just as much, quote, in trouble as for underbilling as overbilling. So you don't want any of those issues. You want to be as honest and transparent as possible. So having people who are really good at their job and understand your specialty and your workflows in the coding billing role is super important. So now that we've, checked the patient in at the front desk, they've seen the providers, they've had the tests done, the progress note has been signed, it's been at the coder and biller, they have fixed anything that needs to be fixed in regards to the claim, it can be sent to the insurance. And a lot of times, most times, it's sent electronically. It depends on how you're set up, of course, but like Medicare only accepts electronic claims. And it's just faster, it's easier, and it's just more efficient. So, we've gone through this process of the revenue cycle where it involves the patient registration, it involves the mid-office with your MAs, your nurses, your providers, right? So that's all the staff so far. And now we're involving coders and billers. So you can see that revenue cycle management touches every single person in this practice in some way, shape, or form. So it's important that you have checks and balances for all of these positions to ensure people are doing what they're supposed to be doing, that they are, not cutting corners, because it's eventually going to come back if they are, and it's going to bite you financially downstream. Join me for the third video of the RCM process, and we're going to talk about what happens at the insurance company, just a brief overview because I've never worked for an insurance, it's just what I'm guessing, and then when we get those remittance back. Smash the thumbs up button if today's video was helpful. Subscribe to my channel if you haven't already. Thanks, you guys. We'll see you next time. Bye-bye.